So as we did with speaking about soft tissue, working perpendicular to fiber direction, as we did with displaying the methodology that Dr. Still describes with setting a hip, what we're going to do is we're going to take an old description or a description from early osteopathic writing, early osteopathic literature, and display it so that you can understand it. And again, keep in mind that the more, when you're writing about a technical application or when you're writing about applying a method, to be accurate so that other people can reproduce it, usually you need to use a lot of words. Even if we think we've used enough words, sometimes we haven't, because one of the things that happens is when something's coming out of our head, we'll take a lot of things for granted that we don't communicate clearly. So sometimes utilizing video so you can watch it back, or having feedback from a live classroom, a live audience can help, because it will be obvious when something didn't make sense because what you believe you said and what they do don't match. So what we're looking at here is a very early description of what Dr. Still spoke about with respect to pterygium. I may be saying that incorrectly, but it's Pythergium. And I'll put the link, I'll put the quote itself below this video, and I'll also put it on my website so that will be clear, and you'll be able to link to the book. It's Osteopathy, Research and Practice, which I usually grab from ATSU, so from the Museum of Osteopathic Medicine in Kirksville. When he's speaking about using his thumbs on the nasal bones and pushing downwards, essentially his concept is he can take pressure off the vasculature in the area so that fluids can pass appropriately and deal with the eye condition. And with many other eye conditions, he says essentially repeat this method. So in the first technical descriptions you receive from Dr. Still that are clear in Research and Practice, which is in 1910, he's speaking about working with the facial structure, not the head, not the cranium necessarily, or not the neurocranium, some of the viscerocranium, if you want to separate it with those terms. Essentially what he's talking about, he may have been standing, but he doesn't say this. He may have been sitting, he doesn't say that. I'll be sitting just so that it's a little bit more clear. Now this angle isn't perfect, but we're going to do our best. So essentially he talks about taking his thumbs, placing them on the nasal bones. You got to be careful, because as you can see, you didn't see it because my thumb's blocked, but if you're coming in a poor way, it's uncomfortable for the patient, they'll blink, so my patient just blinked. So you come in, right, you got to tell them what you're doing beforehand. But he talks about thumbs on the nasal bones and pushing downwards, right? Now what I want you to pay attention to is the patient's chin, because if I can think I'm moving the nasal bones, but I could just be essentially flexing his head on his neck, or creating OA flexion, occipital-atlantal flexion, so I could be doing that. Now what I would say with this method that would probably benefit you, we use the concept of relational motion in a lot of other situations, but to make sure that you're not tricking yourself and that you're actually getting some motion between the nasal bones and the frontal bone, is to have the patient become active. So Dr. Still doesn't speak about this, he just speaks about drawing downwards. But to use the concept of relational motion, and also I'll talk about contact as control and broad contact, right? So in this case, I could just hold here, but then I'm using my thumb pads and that can be quite uncomfortable, especially on somebody's nose. But what I can do is, if I have a broader hold in this case, right? So I come into kind of an odd curled hand. I have my hands essentially in and around the maxilla, right? I could stabilize a little bit better. So this way I could draw. Now what I'm going to have my patient do is I want you to tip your head backwards. So there you go. And let go. Good. And again. And let go. Now here's the thing. I could think there's huge amounts of movement occurring because I'm getting my patient to extend his head on his first cervical, so extend the OA joint. I don't know how much movement's necessarily happening between the nasal bones and the frontal bone, or in the region in and around the orbit. I don't know how much movement's happening. First of all, I know that there's not much movement available. Very, very small amounts. I also know that the patient's moving his head, and I'm not necessarily stabilizing certain parts of it. So I don't expect to have a good understanding. What I expect, if I'm thinking about an eye condition, and this actually works for an eye condition, which it may or may not, it may be useless in many eye conditions, it may be useful, I really don't know. I haven't necessarily used this in situations with respect to eye conditions. But what I can say is that I have to be careful that I don't let the movement of the patient's head trick me into thinking giant movements are happening where giant movements don't exist. Now, because, as I say, the thumb's on the nasal bones, I can't stabilize the head very well. I kind of get in a situation where I'm tricked, What will often happen, and what I will often do, and many others will as well, is you'll purposely have a hold of the frontal bone itself and then use one hand, right? And you can create a draw better that way, or a separation between the nasal bones and the frontal bone, or in the region of the orbit. You'd have a much better understanding here. Now, because I have a hand on the patient's forehead, so this is taking the concept that Dr. Still presented, showing it to you in one way, how he wrote about it, and then modifying it so that I can not trick myself as a practitioner. So I will stabilize the forehead, right? Stabilize the frontal bone, hold the nasal bones with one hand. Now, if I essentially do this, right, pull them apart, obviously that's an exaggeration, that's not going to happen. I do that, and I use my eyes, I can have a better understanding of what may or may not be happening in that region. I can also move side to side, but if I have the patient help me with active motion, I stabilize a lot more, so I can create force external to what I'm applying through the patient's action. So what we're going to have you do is try to tip your head backwards again, and let go. Right? Now, I want you to do that just a lot more gently. Do it again, gentle, gentle, and let go. There you go. Now, his head still moves, so again, I have to understand that I'm not looking for lots of movement. If I feel like there's lots of movement, then it's really just the movement of his head, not the movement between these bones. Now, the signal that somebody like Dr. Still or early practitioners would be using would be resolution of the condition or resolution of the complaint. So whatever was going on with the eyes, if they applied this and then the patient subjectively told them that there was a change in presenting symptoms, they would take that as effectiveness or a positive effect of the treatment. What I will say is that really sounds more like temporal correlation. Things happen at the same time, and we can't necessarily control for other things that may or may not have happened. The diagnostic qualities in the late 1800s, early 1900s were not what they are today, so oftentimes conditions that were presented or conditions that were diagnosed may not have actually been those conditions. They may have looked very similar to it, but not actually been it. That's a bit of a rant. It's not necessary in this situation, aside from the fact that I may use working in the facial structure, not the cranial structure, so in the viscerocranium, not the neurocranium. I may work in the facial structure if people are having things going on with issues with the sinuses or passage, like air passage. So if the nose happens to be sitting awkwardly, right, a broken nose or something like that, you seem to be able to get a positive effect from that as far as subjective feeling in the airway, the ability to take a breath in through the nose. Or at least that's what I've had success with in the past. I'm not saying that I can cure any condition with this. I'm not saying that I can fix an eye with this. I'm not saying that I can fix a sinus with this. But I have seen positive temporal correlation if I work with the frontal bone, or essentially with the nose as a handle for the facial structure, generally speaking. Understanding that even the sinuses are not the same size, they're not the same shape, they're not necessarily particularly symmetrical in most adults or even in most children. So we take it all with a grain of salt. But to bring it all back, we're talking about the concepts of relational motion, the nasal bones in relation to the frontal bone, and some of the normal problems that occur if I just push on the nasal bones, if I just use my hands. I can move the patient's head instead of moving between the nasal bones and the frontal bone. So what I would prefer to do is stabilize the frontal bone with one hand and use another hand to go ahead and move it. Now, it's not likely that I'm going to create much movement because not much is available. And even if there is some available, I may not even be able to create it. But there does seem to be a subjective improvement for many patients when a method like this is used. Sometimes there is a seemingly objective improvement as well. So we take it all with a grain of salt, and hopefully that helps you understand an old written description by seeing it, or by seeing what it might look like, some of the pros and cons with it as well, and then also relating it to some of the concepts that I speak about consistently, that being relational motion as well as context control and control of safety.